So these medications, how they work, there's a lot of controversy of specifically where they work. There's been studies showing that they work in the tissue, and that there's been more studies showing that they work actually in your central nervous system, on your brain and your spinal cord. Sometimes you will see that an orthopedic surgeon will put morphine inside a joint. And there has been studies showing that even though the patient was not injected with that medication, the pain after the surgery has been less because there has been some receptors sensitive to that medication that was put in that joint, so there's less pain. So there's many receptors. I'm not going to go in depth on that. Not every pain medication works in the same receptor, and depending on which receptor is activated, that's when you start seeing the side effects. So some of them will make you more tired, some of them will make you more constipated. Well, all of them will make you constipated, and you unfortunately don't get used to that. Some of them will cause more respiratory depression. So these are the ones that you take, and then it's going to be harder for you to breathe. And again, they work more in the GABAergic receptors, and this is very important because there's other non-opioid medications that they work in a similar pathway, and they can get substantial relief without the side effects of the opioids. One issue that opioids or this type of medication have is that your body will get used to it, and we're going to talk about that a little bit later, and that is called tolerance. No ceiling effect means that as long as you go slowly, you can keep getting substantial amounts of this drug, and you will probably not stop breathing as long as you do it slowly. But if you take too much of it out of a sudden, then that's when you may have some of these side effects suddenly. And some people believe that because they don't see benefit out of certain dose, going higher and higher and higher will get them more benefit. They won't see a ceiling effect, they may not see more side effects, but it doesn't mean that they will see better pain relief. There's a different type of opioid medication that is called Opiate Agonists, antagonists, and there's some of these that are used in chronic pain. These don't work the same way. They were artificially developed to help patients that were either at risk of abuse or that they did not tolerate just the pure agonist in terms of the opioids. If a patient is taking a pure opioid and is placed on this type of medication, they go through withdrawals. And we're going to talk about withdrawals, which is something that many patients ask. So, tolerance. And there's a big difference between tolerance, dependence, and addiction. And I brought these three just so you guys see that it's not the same, okay? And most people interchange those terms. Tolerance is that response of your body. So it's a physiologic response. You can prevent that from happening, in which you will see your body getting used to that medication at a certain dose, and your body will ask for more to get the same relief. It doesn't happen on every patient, but when it happens, usually it's seen at certain doses, and that will be in patients taking morphine 60 milligrams, a fentanyl patch, 25 oxycodone, hydromorphone, or oxymorphone. So you develop tolerance to the benefit in terms of the pain, and you develop tolerance to some of the side effects. So for example, if initially you were having severe tiredness, maybe stomach upset, nausea, which are some side effects seen with these medications, with time your body may get used to those. One side effect that you will never develop tolerance is constipation. Your constipation will get worse and worse the higher you go. So patients that take pain medication, they will need to be on a laxative or a stool softener, which is something that they will have to use as long as they are on that regimen. So dependence. Dependence means that your body will fight you to get that medication. It will do whatever it takes so you don't stop taking that medication. And that is something that nobody can prevent as well. That is a response out of the body. So you start taking this medication and you decide you don't want to take it anymore. You stop taking the medication. And this is what people describe as having withdrawals. The body is craving for that drug. The body wants to have that drug. and they will make you miserable so you can get it back. For most patients in reasonable amount of opioids, withdrawals are not life-threatening. They're a very bad deal for several days, and most of the time, 3 or 4 days after, patients do better. And this is when they get goosebumps, nausea, vomits, diarrhea, and that's the body fighting and letting you know that the body wants that medication back. Okay? Having withdrawals is not the same as being an addict, or having tolerance to a medication. It doesn't mean that you're an addict. Addiction, and I have never in my practice diagnosed anybody with addiction, because addiction is a diagnosis made by a psychiatrist, and that is a behavioral deal. So it's a very serious diagnosis, and there is several factors that involve addiction. Addiction is a compulsive way of your body trying to get these drugs, but you consciously do this. This is not something that you are preventing. So you deny that you're using the drug because you want to have more. Okay, you tell the physician that you haven't been receiving prescriptions, or that your dog ate the prescriptions, that they went down the drain, somebody came in the house, name it. I heard stories that you guys can't imagine. Somebody stole my pills. So one of the issues that is seen along with addiction is selling drugs on the streets. Some patients, they don't like the pain medications, they just exchange those for different drugs. They exchange that for marijuana or for heroin or for other types of drugs. And some patients, they do use that medications in a different way. They crush them, they inhale them, they inject them. So that is an aberrant behavior. And I haven't made in my years of practice ever a diagnosis of that. That is something that is managed and treated by a psychiatrist. It's not an issue that needs to be addressed or treated at a chronic pain clinic, because it's not pain per se. It's something different. Okay, so side effects. And this is something that I see very, very often. I ask a patient, what are you taking? I take a small blue one, I take a white round one, and then the yellow one at night. So very, very important that whatever medications you're taking, you know what they are, you know what the dose are, because that will let the physician know if there's going to be any interaction. Also, it's very important that whenever you're being seen by a physician, it doesn't matter if it is for pain or for something else, that you have a complete list of medications, everything that you're taking, even natural medications. There's many interactions between drugs. And if a physician is completely unaware that you're taking certain drug and they prescribe you something that interacts with that, that's when you start seeing several issues and side effects. So, side effects out of these opioids or pain medications. So let's start with the pulmonary side effects. They decrease your ability to breathe, increase the CO2, which is what you exhale when you're breathing, and that per se could be fatal. You can die out of that. Especially in patients that they have been through a concussion or any type of head injury, they per se have a less ability to respond to low levels of oxygen, so these medications you never prescribe to that type of patient.
Dr. Albino?
Yes.
Is that if they've ever had a concussion, or if it's a recent concussion?
Mostly in the acute.
Okay.
Mostly in the acute setting. So gastrointestinal, and this, I shortened this list, but there's a huge list of side effects through the gastrointestinal system. Delayed intestinal transit, and that's where the constipation comes. And that could be severe to the point in which stool will stick around the large intestine, and patients will have diarrhea, and they come to the clinic saying, well, I'm not constipated, actually I have diarrhea. You're constipated to the point in which your large intestine, where the water is absorbed, is just covered in feces. So because it's covered in feces, it cannot absorb the water, and the water just goes through. So that is fairly common. I see it very often, and actually instead of not taking laxative, patient needs to take laxative aggressively just to clean the intestine. And that has to be done for several weeks before that completely gets cleaned up. And again, constipation, which comes before that. Delayed gastric empty is very important in diabetic patients that they per se have delayed gastric empty. These medications will just exacerbate that. And again, this is something that your body doesn't get used to. This just gets worse as time goes by. Genitourinary